Thank you very much, Chairman, and to my colleagues as well. There will be a little bit of overlap with what you've discussed, but it's important that we consider, these are just my disclosures. So I think we often see these patients come into our emergency department, and it's difficult, as you've just mentioned, to differentiate sometimes how do we approach the management of these patients. And if you look at the echocardiography, there may be a very different echo picture when we look at these patients. One is a 60-year-old patient, one is an 80-year-old, and you can see the difference in their echocardiography and also how they present if you look at the X-ray findings at the bottom. So this may not look so severe, but actually this is a very sick patient, and important that we diagnose that immediately. So in this acute situation, you need to understand what has caused this crisis for the patient. Is there ischemia, uncontrolled hypertension, renal dysfunction? These are just a few. Is there an infection? Is there fluid overload? A burns patient may have a specific set of risk factors. Is it a motor vehicle accident that could have precipitated this acute event? So we know that the majority of patients presenting with acute heart failure are elderly. So they come with their own problems, especially the comorbidities. And they can really present with different degrees of complexity. So if we look at the pathophysiology, there could be myocardial reasons, renal, vascular, or neurohormonal. And each of these may affect how that patient then presents to the emergency department. And there may be different triggers that then cause the patient to deteriorate acutely. And I think one of the points that you've made as well is that the interventions that we do cannot stop with the acute event. We have to try and use that event to prevent that person being readmitted to hospital several times because the cause of the condition was not diagnosed and managed. And this is, again, just looking at these different, just a different cartoon with the same idea, looking at what caused the circulatory congestion in the patient. Some may happen in seconds and others may occur over days. And just looking how these cytokines then affect the patient. And this is on this basis that our management has been adjusted over time. As we understood the inflammatory response better, how the sympathetic nervous systems interact and the RAS system. And this is why we do have agents and medications and interventions that can make a difference to how the patient responds. And this is typically what we would see in the emergency department, this kind of chest X-ray where the patient is in acute distress and with evidence of LV dysfunction on echocardiography, if that is immediately available. And there's a myriad of things to consider. Most importantly is to really evaluate what could have caused this particular patient's deterioration and how can we mitigate against it. So what is our goals of treatment? First of all, we need to alleviate symptoms. We want to improve the congestion. We want to improve the hemodynamics, preserve the renal function, and avoid worsening of the underlying disease. And then not just the short term, but also the longer term morbidity, especially these recurrent hospitalizations. Try to reduce the length of ICU stay, avoid mechanical ventilation if it's possible, and also this reduced mortality that is now possible with the interventions available to us. So when the patient initially presents, we can look at the systolic BP as a quick measure of where the patient sits. If they're greater than 100 millimeters of mercury, we can use vasodilators, especially nitroprusside. There are newer agents available. If the blood pressure is borderline, we may have to have a combination of agents. And if they're less than 90, we need to reduce the preload and use inotropic agents to support the patient better. So this looks very busy, but again, as Dr. Sheikh had shown you, again, this wet and warm idea and the dry and cold, that's really the patient that's the worst, hyperperfused, hypovolemic, and there you can consider even a fluid challenge. So it's quite important that you make that assessment if there's adequate peripheral perfusion or not. And then to look at your various agents that would be appropriate in each of these situations. Also importantly to understand that with using an inotropic agent, you may induce an acidosis, and the perfusion of the patient may be affected, and to consider that when you reevaluate them. So there's been some recent heart failure studies. Some of these have looked at different interventions in this acute event to see if there's any way that we can improve even more than what we usually used. And importantly, that in all of these studies, there's been a focus on the patient with diabetes. In some, there were non-diabetic patients added, and they could either have reduced ejection fraction or preserved ejection fraction, depending on the circumstance. If we look at the different stages, there's this immediate management, intermediate, and then pre-discharge. This is difficult to read, I apologize. But again, just that there's this need for determining the etiology, then looking at what immediate intervention would save the patient's life, and then continuing with the pre-discharge and seeing how the patient would then avoid having to be readmitted to hospital on a regular basis. One of the latest studies is the Impulse study. As you know, with the EMPA-REG, with reduced ejection fraction, there was a very significant early onset benefit on the patients with heart failure when they used the SGLT2 inhibitor empagliflozin. And this was duplicated in the DAPA-HF studies. But there was no study yet done in the acute event. And so the Impulse study was the first done in this group of patients, 530 of them in acute heart failure. And when we look at the placebo arm, this was usual therapy. So it's not that they weren't treated with anything, but on usual therapy in a group, empagliflozin 10 milligrams was added. And then they were looking at a composite endpoint of death, adverse events of heart failure exacerbation, time to first heart failure exacerbation, and then a 5-point difference in quality of life to see if these patients benefited from this medication in the acute setting. And what they showed with inclusion-exclusion criteria quite strict to be able to differentiate these patients and avoid any kind of interaction of an inclusion criteria or exclusion. Notably, if the patient was in severe kidney failure, as we know, the SGLT2 inhibitors are at the moment in different countries registered up to an eGFR of 20. The less renal function, the worse, or they don't work as well if the renal function is deteriorated. If there's any acute coronary syndrome, MI, stroke, or TIA, and any other acute events that could put the patient at risk. But again, there was a large number of patients that could be included, and they looked at these criteria to be able to diagnose who they thought might benefit from this medication. And it was important that mandatory inclusion criteria was that they had persistent dyspnea at rest or with minimal exertion and signs of decompensation. Sorry, I went the wrong way. And they looked at all-cause mortality. And importantly, in this group of patients that were quite sick, they were able to reduce in the EMPA group versus the placebo group still an improvement in 6.2% of patients, the mortality rate. And at least one heart failure exacerbation was reduced by 12.6% in the EMPA arm. So it's really added on to our understanding and our management of these patients because of the EMPA-REG and the other heart failure studies with the SGLT2 inhibitors that have shown benefit early on in the treatment of these patients. So their conclusions were that if they were hospitalized for acute heart failure, if they were treated with empagliflozin, 36% of patients were most likely or more likely to experience a clinical benefit versus those on usual therapy. It was consistent in patients with reduced ejection fraction or preserved, and in patients with de novo or decompensated chronic heart failure. It was well tolerated with overall safety data. Again, no real significant side effects experienced except the usual ones that the SGLT2 inhibitors have shown. So many of our patients are elderly, and one has to understand that there's a frailty index and an immobility that may contribute as well. And this comes to that personalized intervention, as you've spoken, that you have to understand and also look at things like polypharmacy, which might be quite complex in the elderly patient. And it also depends on their social circumstances, if they can actually be compliant with what you have prescribed for them. We know now that diabetes is not just an endocrine disorder. I think somebody's advertising something here. But that because of the way that they work on the kidney with the sodium loss for each glucose that you lose, you have this improvement and the diuretic effect. And that this cardiovascular risk of type 2 diabetes is really now better addressed by using the SGLT2 inhibitors in addition to our other therapies. So with heart failure specifically, or any cardiac disease, this is added to our armamentarium in treating these patients. And it is important that we consider how they can be used safely. And it's a low dose, the 10 milligrams empagliflozin. And I'm sure other SGLT2 inhibitor studies will follow. DAPA-HF was done with patients with or without diabetes, because as this agent was first developed for diabetes, they then understood this improvement in cardiovascular outcomes. And in the DAPA-HF with reduced ejection fraction, I just included the slide to show you how these, again, over time have evolved, and how the newer studies also in patients with chronic kidney disease have shown improvement with the SGLT2 inhibitor. So we're sort of starting to understand how these agents can intervene and manage our patients with heart failure. This is just looking at patients who had comorbidities also by glycemic status. And again, as you've mentioned, you know, many of these patients have comorbidities that, again, may influence their outcome. And we have to be aware of these and see which ones we can intervene and address. This is just looking at their hospitalization for heart failure, because, again, if there's an urgent heart failure visit, that would, again, impact on the patient's outcome in the long run. And with DAPA in this DAPA-HF study, that was significantly reduced. And again, significantly, this is why they've done the study with early intervention in the acute heart failure setting, because of this divergence of the curves early on, very different from any of the other interventions that we've seen, specifically in cardiovascular protection and outcomes. This is just cardiovascular death, again, just showing the benefit of how this agent could make a difference. And this is on top of usual therapy. Slides have disappeared. So on the patient where there's renal dysfunction, it is important, again, sometimes you may need to do acute dialysis on these patients. We do know that excessive diuretic therapy, again, may not be favorable, depending if the patient's perfusing well or not. And one has to be very careful that not to over-diurese at the same time, especially if there's hyperperfusion. And to try and stabilize the hemodynamics of the patients. So the monitoring that we do, invasive monitoring, has become a useful way to looking at the patients. Non-invasive ventilation with CPAP is a good way to get the patient over the acute event. CVP may not be enough and may not be adequate. So if you can look at lactate levels, and also the SVCO2 may give you more information than just the blood pressure measurement. Lactate levels that improve over time, again, important just to watch if you're on inotropes, because that may affect the pH and the lactate levels. I hope this has been of use to everybody, and that if you're in the acute situation, you'll have a better approach to your patient in the future. Thank you very much.